Thank you very much to the organizers for the invitation to speak and for putting together fabulous meetings. Really great to get the cross-pollination at these meetings. And I want to talk a little bit about something I really enjoy, which is using volume restoration as well as laser resurfacing to try to optimize my facelift results. I'm a facial plastic surgeon in the U.S. These are my disclosures, but really not pertinent for this talk. I'm not supported by them for this meeting at all. So when we look at volume loss in the aging face compared to a youthful face, we see in the periorbital region, of course, as well as in the nasolabial fold and the marionette region along the jawline. And to me, it creates at least as much, if not more, effect with aging as the traditional or classically understood descent, where there's not much descent to the brow, perhaps more laterally where there's lack of frontalis muscle insertion. And the jawline in this patient, really, if you put a little filler or fat transfer in the prejaw sulcus area, you can get pretty good effacement of that jawline. But for a more durable effect, you can also use fat and further improvement of the marionette area with a facelift. In the periorbital area in particular, we have to pay attention to bony atrophy that occurs with radial expansion supramedially and infralaterally, which, if we aren't careful, can lead us to chase our target of for a brow lift up the forehead. So if we're taught that the brow should begin and end on the supraorbital rim, and it's atrophying and therefore advancing radially upward, then we're going to falsely elevate the brow, which is what I think occurred in this patient. And if you look back then to our younger years, the height of the brow above the lash line is probably no higher than the height of the palpebral fissure. So that's what I like to use instead as a guide, and of course account for any ptosis or squinty smile in evaluating for that. The other thing that I think occurs is there's an optical illusion where the lack of highlight beneath the brow, that shadow effect, makes it look like the distance is decreased. And so I think our brain is telling us to recreate that, and the only way classically we knew how was with elevating the brow, and then you get more of a highlight above the sulcus in that case. But again, I think that's falsely elevated. So this patient wouldn't need a brow lift either. The height of the brow above the upper lid is no greater than the height of the palpebral fissure. So just a rough guide to keep in mind in these patients either. So with fat transfer, the equipment's inexpensive. I think it's very high satisfaction as long as you discuss the variability of it with the patient. It's durable, it's natural. There's a little more downtime, a second week instead of just one week to 10 days for traditional facelifting results. And we might need to repeat it at a year, and our practice is probably only 5%, maybe 10 at the most. And it's easily combined with other procedures, as we'll show. You can, of course, use fillers for these areas as well with pretty much ease, and the volumes would probably be about a third of what we'll show. And all that equipment can be obtained for probably less than $1,000. Typical markings for a patient, a typical presentation typical patient that presents for facial rejuvenation. Won't belabor that, but key areas if you're doing facelifting is to pay attention to the areas that we're lifting and make sure that we don't put fat into a big dissected plane. So for subcutaneous in these areas, and as well as if we're releasing the mandibular ligament, I typically do that superficially or subcutaneously, and from the segmental aspect. But anyway, we're creating pockets, and if we put fat into those pockets, of course, it's not going to stay as well, and it may sag down in unwanted areas. So you either have to put it more deeply or just wait and do synthetic fillers afterwards, or come back and do another fat transfer later. So I won't belabor the technique, but basically gentle care of the fat, and no more than 2 cc's of back traction on the plunger, and centrifugation. I still consider that gentle, some don't, but it works very well, and nothing really has definitively been shown to me to be superior. We are now adding PRP at a ratio of about 1 to 10, and it certainly hasn't caused any problems. There may be a trend toward decreased bruising and retention. We use 1 cc syringes to infiltrate and use 0.9 and 1.2 millimeter cannulas. 0.9 millimeter cannula mainly for just the infraorbital rim and superficially at that, and the rest is all 1.2 cannulas. We only put about 0.1 cc's in per 2 to 5 passes, so it's just a patient, deliberate process to try to minimize chance of irregularities, which happily for us has been quite minimal. You want to make sure you localize with epinephrine to minimize the chance of intravascular injection through vasoconstriction. And for me, timing is such that we do it after any lifting procedure is done. So the type of facelift, really any facelift can be done with fat transfer. In our case, I like the results with the deep plane facelift, in my hands the best. And basically it involves release of the osteocutaneous and fasciocutaneous ligaments, zygomaticocutaneous and mandibulocutaneous ligaments being the most important, I think, in order to get the best redraping of that platysma and SMAS with the overlying skin. One benefit, particularly for laser resurfacing, is that you have a thicker flap then in the areas where you've gone into the deep plane because you've got that platysma under the skin. And so it's safer for lasering that as opposed to just the subcutaneous flap, which, as I'll show, is just in the more lateral aspect of the face. So it can always come back later and laser that. But anyway, it allows some protection for that, in addition to what I think are benefits for overall contour and confidence in getting the best result that I think I can. So the platysma muscle is important for that, and you want to go just beneath the platysma muscle. We usually enter, first of all, along the line from the zygomatic arch area, lateral canthus, to the angle of the mandible, and usually inferiorly along that line. There the facial nerve is more protected by the parotid-masteric fascia, and then extend anteriorly, usually near the oral commissure for best release. So quick video, just showing, if you could play that video, please. We've already done the subcutaneous elevation, and we're just sort of indicating the line from lateral canthus to the angle of the mandible, and we've begun to elevate into the deep plane there, and you can kind of see the platysma reflected upward in the deep fascia below. Another picture there, a little closer up. Sorry, I couldn't get any closer than that. But we're indicating the overlying platysma fibers, and then the deep fascia protecting the facial nerve branches below that. So just showing a range of results that we can achieve with the spectrum of aging, of lipatrophy that we tend to encounter. In this patient who had fairly mild atrophy, she was very happy with this restoration of the midface with just 3 cc's along the foreorbital rim, 1 medial lateral deep and 1 superficial, and then a little bit in the anterior lateral cheek. I backed off a little bit in the lateral cheek. I usually do 3 in the lateral cheek for most patients, but she already had pretty good definition, and I was glad we stuck with that. I think she's nicely restored there. And she was at least as happy, as if I didn't mention it, with the midface improvement as she was with the jawline. So a little further along the spectrum, a patient with moderate atrophy who had a facelift as well as periorbital volume restoration. She also had an upper lid blepharoplasty later on. Did not do it at the same time in this particular patient, but in this patient we did 3 cc's along the infraorbital rim, and we added 2 in the supraorbital rim, along with, again, the blepharoplasty to create that improvement. She did not do laser resurfacing at the same time, but we'll show some at the end. Patient with more advanced atrophy, and the numbers we used for her, we added another cc superficially in the infraorbital rim to get a total of 4 along the infraorbital rim, and then 3, so we added 1 in the supraorbital rim as well. We typically do blend with the lateral canthus and then typical amounts in the anterior lateral cheek. She didn't want a tremendous amount of cheek, and I think that achieved a nice effect anyway. We did do her temples as well. No brow lift in that last patient, but I think she, again, that highlight that's beneath the brow creates, I think, the illusion, or at least the appreciation of a higher brow. In this patient as well, where we pushed it a little bit with more in the supraorbital rim, in this case 4 cc's in the supraorbital rim, and 4 along the infraorbital rim, and I think that got a decent improvement of the upper lid show, and a nice new parallel line between the reflection, the upper lid sulcus there, and the lash line. And a little bit of lift of the tail of the brow, which I think of as like a pendulum effect, where the skin is a fairly fixed string length, and the bone is behind it, so if you add volume, it's really just going to go anterior superiorly. So adding laser resurfacing, any laser, of course, will work for resurfacing. We like the fractional CO2 laser for speed and efficacy. And again, just want to make sure that we note that we don't laser the lateral aspect of the flap where it's just subcutaneous for this type of facelift. And if you're doing some application or imbrication where you've elevated a skin flap further perhaps, then just want to make sure you don't laser over that. At least when you're starting out, getting used to your laser, you can get problems that take a long time to correct. And just so laser more medially, and of course periorbital, and perioral are very helpful. So I won't belabor the tightening effect that you get. Probably most of you have done laser resurfacing and have seen that tightening effect immediately while you're doing it. Typically with the second pass we see that, and that's always reassuring that they've got an improvement. This patient happened to not be able to do or forget to do the hydroquinone beforehand, so we didn't do laser resurfacing simultaneously, and it just gives us a nice example of the improvement that she got initially with the lift alone, improvement of the lines, and then further improvement after laser resurfacing. And just the perioral area is all she was requesting. So in summary, we're not just lifting anymore. Of course, we're refilling and resurfacing. And fat transfer is my choice for surgical restoration of the volume. It's durable, it's natural, a little bit more downtime, but we do have to be judicious with it. And we can do the same thing with synthetic fillers, but just a ratio of about 1 to 3. Laser resurfacing also pairs well with surgery, and be careful over the lateral flaps. So thanks very much.